Okay, everyone, it is just about 2:30 Eastern Time, so I'm going to go ahead and get this event started. This is Natalie Matthews from Apt Associates. I just wanted to give a very brief welcome and one quick logistical reminder. So you are all muted today, all participants, but there are still two important ways that you can interact with us throughout the event today. So please go ahead and be sure to click the chat button on your screen to send messages either to one another or to any of the experts that we have with us on the phone. And please also be reminded that you can submit a question to us through the Q&A box if you have something specifically that you would like a response on. The event today is being recorded, and the recording along with slides will be posted on the HUD Exchange. If we are unable to answer your question for any reason, we will ask you to please go ahead and submit those through the Ask a Question desk on the HUD Exchange, and we'll get back to you that way. I'm going to turn things over now to Karen de Blasio, who is going to give an introduction to our first speaker today. Karen?
Hi, everybody, and welcome. This is Karen de Blasio. I'm the Director of the Program Coordination and Analysis Division in the Office of Special Needs Assistance Programs, or the SNAPS office. And it's my pleasure to introduce to you today for the call Mr. John Gibbs. He's the Acting Assistant Secretary for Community Planning and Development here at HUD. John, go ahead.
Thank you, Karen. As Karen has just shared, my name is John Gibbs. I'm the Acting Assistant Secretary for Community Planning and Development here. And on behalf of Secretary Carson and all of HUD, I want to thank you all for being a part of this call today, and thank you for the work you're doing to assist people experiencing homelessness, especially under these really challenging circumstances. Your dedication to serving those individuals and the families who are experiencing homelessness is critical even under regular circumstances. But now, in the midst of COVID-19, providers across the country are really stepping up and continuing to provide the vital lifeline to people experiencing homelessness, and often that population is at increased risk of suffering due to various factors, especially COVID-19. So thank you for really stepping up during this time. I would also like to thank all of my colleagues here at HUD, especially in our Office of Special Needs Assistance Programs, who have been really doing a great job and working tirelessly to make sure you, our stakeholders, have everything you need to respond to this crisis. So I just really want to give a great big thanks to all of my colleagues here, especially in our SNAPS office. And speaking of responding to the crisis, I just want to stress a very important point, which you may already be aware of, but it bears saying again. Because the situation is evolving so quickly, we really want you to continue to take action and be proactive in your response. You can do this through at least two ways. One is reaching out to the essential partners in your community, including your local continuum, your local police or public health department, your emergency management officials, local government, and community health care providers. And in partnership with your community partners, be sure to be implementing a system-wide response plan to be able to safely and effectively keep your vital programs operational while avoiding the spread of infection and coordinating medical care for those who need it. HUD, as well as our federal partners at CDC, VA, HHS, and Healthcare for the Homeless, who are here to answer your questions today, are working together to provide ongoing guidance to help you work through these challenges. Please continue to check the HUD Exchange website to access the latest updates, including additional funding opportunities for COVID-19 response, waivers, as well as other information. So I just want to close by saying thank you again for your tireless work in caring for those who are vulnerable. It is really a great work that you're doing. I really appreciate that. It's going to make a huge difference in curbing the spread of COVID-19. Thank you very much.
Thank you, John, for those words of encouragement. I'd like to hand it over now to Norm Suchar, the Director of the Office of Special Needs Assistance Programs.
And Norm, just a quick reminder to unmute yourself on your computer screen. You should be good to go. Okay, it looks like Norm is not able to join us quite yet, so I'm just going to step in real quickly and keep things moving. So I believe that Marlisa Grogan from the SNAPS office can get the content started and just introduce us to all the panelists and resource advisors that we have here today. Marlisa, are you able to jump in now? Okay, no audio from Marlisa either. Hold on one second, guys. She's joining.
Oh,
awesome,
great.
David. Go for it. But she's joining.
Sure. So for folks who have joined us before, for our office hours, our panelists will be familiar, and our process is the same as our last several. We're fortunate enough to again be joined by Emily Mositis from the Risk Population Task Force at the Centers for Disease Control. And then, as you know, our team from the SNAPS office at HUD headquarters, Norm Suchar, the director, Brett Esters, senior program specialist, Marlisa Grogan, and Abby Miller will all be answering questions through the chat box as we go. We're also fortunate enough to be joined today by our CPD director for Denver, Katie Burke, and our senior CPD representative from Chicago, Aaron Weaver, who will also be answering questions. So please do use that chat box to enter questions. And I'll turn it over to Marlisa to get us started.
Okay. So can you all hear me?
Yes, sounds great, Marlisa.
Great. So if you can just take us to the agenda slide, you'll see that we're going to first have some updates from the Centers for Disease Control and Prevention, and followed by the SNAPS office at HUD. And the VA will also provide an update, as well as Barbara DiPietro from Healthcare for the Homeless, and then we will turn it over to Q&As. Next slide, please. Emily Mositis, please take it away. And Emily, you might be on mute. Okay. Maybe we could switch the order, and could we have Barbara DiPietro do her update for Healthcare for the Homeless, and then we'll circle back to Emily?
Sure, that's just fine. I just had a verbal update just so that folks knew the resources that the National Healthcare for the Homeless Council had available. We have already put out an issue brief that goes into why homeless populations are high risk and why this population needs to be established as a priority population in all communities, as well as the policy actions that need to happen fairly quickly so that we can be changing the systems around us to be responsive. Next week, we will be coming out with our second issue brief, and mostly this is just to identify what the common issues have been, particularly across our healthcare for the homeless and other healthcare providers, but also that has been articulated by many of the continuum of care and other emergency response folks, and just kind of aligning the resources that have been put out to date. CDC and HUD and all of our partners have put out so much that just kind of aligning where that should go for folks who are currently swimming in all of that. And then actually, as we speak, we are also doing some town hall webinars at the National Healthcare for the Homeless Council. Right now, the folks from the Seattle response team are presenting. If you go to our website, you can register for these and get the recording. These will be every Friday for the next several weeks, mostly looking at the healthcare response and how those responses are partnering with others in the community. Also want to call attention to the fact that we have a very generous opportunity from Kaiser Permanente to do $25,000 to $50,000 cash grants unrestricted to help particularly healthcare providers and other types of providers meet the intense needs they have right now for supplies and other other immediate needs that cash might be very helpful for. All of this information is available at our website, nhchc.org, and we're also maintaining a dedicated COVID-19 page where we're collating a lot of these resources from our federal partners as well as local guidance that is becoming available that other communities can use as a model for their own. So that's my update. I really appreciate being here today, and I'll turn it back over to Marlisa, I believe.
Yep, thanks, Barbara. And now let's see if we could hear from Emily at CDC.
Can you hear me?
We can hear you.
Oh, wonderful. Okay. So many conference call issues. Days. Okay, so hi, everyone. This is Emily Mathitis from CDC, calling in from the at-risk population task force on the coronavirus response. I'm just going to give a quick update on a couple things that we've been working on. And I don't see how to change this. There we go. Thanks. All right. So just an update in terms of numbers. This is a little bit delayed because this is as of yesterday, and CDC does have a reporting delay. But essentially what we're seeing here is we're seeing community transmission of the coronavirus across the United States. We are all in this together, and we all need to be enacting our plans for how we're going to protect people who are experiencing homelessness during this crisis. So next slide. As a reminder, we have two pieces of guidance up on our website. We have one for shelters and other service providers that we mentioned the last 2 weeks. And then we have a new one as of this past week, which is for people who are experiencing unsheltered homelessness. So I just want to go through some key points from that. If you go to the next slide. In this document, we again emphasize that you really need to have community-wide planning. So forming those coalitions that are happening across the country on the community level is going to be very important for protecting people experiencing unsheltered homelessness. Continuing housing linkages is a really high priority. So if there is individual housing available, we want to make sure people that are sleeping outside are getting that. We want to be communicating very clearly with people who are experiencing unsheltered homelessness. We want to make sure that people who have tested positive and don't need to be hospitalized have somewhere that they can go to be isolated, and they can get the care that they need and be protected and help protect the rest of the population. So we're also encouraging communities to not clear encampments unless there's individual housing options available. We do want people who are in encampments to spread out as much as they can, so 12 feet by 12 feet per individual. And we also want to make sure that those people have access to hygiene facilities. So those are the high-level points in the CDC guidance for people experiencing unsheltered homelessness. If you go to the next slide, we mentioned a couple things that were upcoming last week, and every time I predict when something will be able to be posted on our website, I am always wrong. So we do have a couple things that truly are coming. We have FAQs related to COVID-19 and homelessness. We'll have a screening tool for shelters to use and for respiratory symptoms. We're also going to have flyers and posters for communicating with people experiencing homelessness specifically. And eventually we'll have some shelter guidance updates. So please keep an eye on our website for those updates. And please, if there is any confusion or questions, please feel free to reach out, and we want to make sure that you know that we're standing with you and we want to support you in any way that we can. Thank you.
Thanks, Emily. Can we turn it over to the VA now before HUD's update? John Kuhn?
Yep. Can you hear me?
Yes.
Very good. Okay. So I don't have slides, but I do want to point you to a website before I get started so you can find all the information about SHARE. This is John Kuhn. I'm the National Director for the Supported Services for Veterans Family Program with the VA. And that website is www, of course, va.gov/homeless/SSVF. So the materials or the guidance I'm about to share is available on that site. So there are a number of steps that we have taken to try to address this crisis. This guidance is literally evolving by the day, but I can tell you for today what it is that we are identifying veterans who are at high risk, which we consider those who are 60 or older and or have some sort of underlying health vulnerability such as lung disease or immune deficiency issues. These veterans are eligible for placement in hotels or motels. The idea here is we want to get them out of congregate living environments, such as often we find in municipal shelters, for instance, or encampments, get them into a scattered site location where their exposure is not as great. This would be for people at risk, vulnerable people at risk, not symptomatic folks with COVID-19. The reason why is that we don't have the capacity within SSVF to adequately medically monitor them. And also, frankly, right now we don't have relationships with hotels and motels that would take symptomatic folks. But this is the hope is to reduce people who are at high risk from contracting it at all. This is a limited resource, so we want to make sure that if you access it, you work with the local VA medical center and your SSVF grantee to prioritize those who are at highest need. As in the coming days, as our grantees are able to expand capacity in this area, we hopefully can create more slots as well. The second piece that we're offering is we certainly, as everyone is aware, there's reduced activity in PHAs. With the shutdowns, it's hard or impossible to complete HQS. So in lieu of losing these apartments, what SSVF is doing is paying the FMR to place veterans in housing where that housing is likely to pass HQS, and you have to judge likeliness based on hopefully previous relationships with that landlord, because quite frankly, the only places we're doing placements right now is where you have those relationships. People are on lockdown and there's not a lot of housing navigation going on. It's mostly housing navigation by phone call. So if you have a previous relationship, you're confident they can pass HQS, we don't want to lose the apartment. We certainly don't want to keep that veteran household in homelessness. SSVF will pay for the FMR until PHAs are back running or that some resolution has come for completing voucher and HQS. Again, questions on that, do connect with your HUD-VASH teams and also to your SSVF grantee. Third thing we've done is we've lifted some of the restrictions on prevention. We do recognize in a lot of communities that there has been efforts made to prevent evictions, but that is uneven. Some communities have blocks against eviction, some do not. We want to make sure people are able to stay in their housing. So in currently California, Washington, and New York State, we expect to expand that, by the way, but again, that's today. We will expand it as federal disaster areas are named. And in fact, I think several more states were added today. That what we have is a stage 2 screener, we call it. It basically is the more involved screening process for homeless prevention. We're dispensing with that. So the ability of our grantees to deliver prevention assistance is greatly enhanced, so they can forestall evictions where people would be more likely to end up homeless. So that is effective immediately. And also requirements that they spend a certain percentage on literally homeless has also been waived during this crisis. And then the last piece is for food assistance. SSVF has limited in the past food assistance to emergency assistance. The thinking there is that either through SNAPs or local food banks or food kitchens, you can get food as you need it, and limited our emergency assistance on food to $500. That cap has been lifted in case there are some local issues around, just being able to access these resources because of staffing lockdowns or travel lockdowns. That assistance is temporary, or that limit is temporarily suspended. So that's all I have, and I'll pass it back to you, Melissa.
Okay. Thanks so much, John. I am going to start with the HUD updates, so if you could change the slide. Thank you. So we are going to provide a number of updates, starting with immediate steps that emergency shelter providers can take, followed by highlights from 2 new resources that were posted on the HUD Exchange, an update on the MEGA waiver that would impact the Continuum of Care program and Emergency Solutions Grants program, an update on the grant amendment process, which would also impact making changes to ESG and COC grants, and then as well as an update on the proposed stimulus funding for ESG. Next slide, please. So most communities are at the point where taking action is now is just critical, and we wanted to take the time to start out our HUD updates with some immediate steps that shelter providers should plan on taking pretty much after this call. So the first thing is to establish a point of contact at your local public health department, or contact the HUD AAQ to help identify that contact if you haven't done so already. This can be done by shelter providers, preferably in partnership with your Continuum of Care, and if you are a collaborative applicant, that is just a key contact that you need to have immediately. Both your public health department or emergency management official, they are your partners, and you should know who they are and be in constant contact with them at this point. And the next thing is to start adjusting shelter operations. I'm going to go into more detail about that in a second when we review the highlights of the shelter management resource just posted on the HUD Exchange. And at the same time that you're working on making those adaptations to your normal shelter operations procedures, working in partnership with public health, emergency management, your city or county, identifying alternate sites for people who test positive for COVID and those who are symptomatic. So this would be the ideal way to be able to keep shelter residents who are asymptomatic healthy, and then not needing to designate areas within the shelter space, which is especially difficult in shelter settings, to isolate and quarantine. But if alternate sites are unavailable, or until they are made available, it's critical to have a plan for isolating or quarantining within your shelter space. So now is the time to be setting those areas up and knowing how you're going to negotiate that within the shelter if necessary. And then identifying overflow shelter accommodations for those without symptoms. And that is for when your shelter reaches capacity, which is typically the case under normal circumstances, and even a higher likelihood now under these outbreak conditions. Next slide, please. So the guidance that we just posted on the HUD Exchange this week highlights shelter management considerations during an infectious disease outbreak. So one thing that is important at this juncture is screening for symptoms. So shelters should, at intake, be checking in with shelter residents, looking for COVID-19 symptoms, which include cough, fever, shortness of breath, temperature at intake, and at that point to start separating people with symptoms. This could mean putting them in accommodations that are separated from those who are asymptomatic within the shelter setting if need be, or ideally accessing alternate care sites within the community where those with symptoms can receive care. Adjusting operations, that means implementing extensive cleaning schedules, disinfecting commonly touched surfaces, disinfecting, you know, even more than what you would ordinarily do. But that's a way to effectively curtail the spread of germs, of the virus, and doing that on a regular basis. So having a routine that's just followed, and also expanding the use of outdoor spaces. So where you can use outdoor spaces to space people even further apart, that's especially useful when, you know, for periods where you're eating, where people are eating. Also staggering dining schedules, using prepackaged meals, and then converting to 24-hour access so people aren't turned out for parts of the day where they don't have a place to go. That's important. And then establishing the alternate care sites for healthcare providers so that they can offer medical care and sheltering. These are non-traditional environments, and a number of communities across the country are using hotels and motels or large public spaces like community centers. So it largely depends on what resources you have available in your community. But if you are working in partnership with your emergency management officials and public health department, you know, they can help, and actually are the primary entities that are responsible for identifying those places for people who are test positive or who are experiencing symptoms. Next slide, please. We want to emphasize, and you've heard this if you've tuned into past office hours, that closing a shelter now during this public health situation, it could have very serious health implications for those who are typically served in your shelter, and it can also increase the risk of disease spread within the community. So we just want to emphasize that you all are the front line and a lifeline for people who are living in sheltered and unsheltered situations. And now more than ever before, providing shelter and providing street outreach are really critical services to your community members. Continuums of care, leadership, collaborative applicants, you should be actively reaching out to your shelters, both publicly and non-publicly funded, whether they're receiving ESG or whether they're not. They need your assistance to both document their resource needs and help problem solve. Continuum of care leadership can go a long way to try to troubleshoot and make sure the doors of shelters stay open. And if you are facing the tough decision to shut down your shelter, there are steps you can take. We know that you're facing many challenges right now and encountering many risks, and limited supplies and staffing are real problems that you all are facing on a daily basis. But if you can please turn to the next slide. We want you all to know that we here at HUD are here for you all. We want to be a support, and that there are other supports that you have within your community. So if you're facing the possibility of shutting your doors, please reach out to your local public health partners, emergency management partners, to see if staffing and supply resources can be accessed locally. It's really important that continuums of care and shelter providers make sure that these partners, who may not be as nuanced in the homeless crisis response system and how critical it is, make sure that they understand the ramifications to the community if your site needs to be closed down, what an essential service it is, and if it's no longer available, the impact that it's going to have on the community. Another thing that you can do is work with them to plan for alternative sheltering, either non-congregate solutions like hotels or motels, or establishing overflow spaces. and it's really a both and. Overflow is necessary once shelter capacity is reached, which is going to happen faster when you're practicing the social distancing and changing the outlay of your shelter plan. But it's also a matter of considering where the alternate care sites that are going to be available to those who have symptoms or test positive. And then finally, please reach out to us. The sooner the better if you feel like this is a difficult decision that you're going to have to make. Reach out to your field office or a SNAPS desk officer that you know, or submit an AAQ, because we do have HUD technical assistance providers who are deploying throughout the country, and that kind of TA is available to you. So please don't feel like you are facing this on your own. Next slide, please. The second guidance document that we posted is on protecting the health and well-being of people in encampments during the COVID-19 outbreak. The bottom line is that if you can house someone, if you can find permanent housing for someone from an encampment, by all means, please do that. That is always the preferred resolution for someone who's living in an unsheltered situation. Continue to do outreach and engage those who aren't unsheltered, and don't clear encampments. And the more that you can impress this upon your city officials, county officials, the better, because the more that encampments are cleared, the harder it is for service providers to maintain those essential connections and to ensure that people who are sick are getting the medical care that they need. Another really important consideration is sanitation and social isolation measures that they're implemented in the encampment setting. So while it's not preferred that people are living in encampments or unsheltered situations, there are sanitation measures and social distancing that can be put into place to make it a safer situation than if sanitation and social distancing is not practiced. Emily at CDC described the CDC unsheltered guidance that went out, and we highly recommend that you all also review that guidance, including measures like spacing out tents and sleeping areas 12 feet apart. Symptom screening is also important for people who are living in encampments and should be conducted so that those who are living there can be referred to care when they need to be. And providing education on the transmittal of COVID-19 and offering hygiene products is another really important part of street outreach in encampments. Just encouraging people to hand wash, to cover the cough, to not share utensils or food or cigarettes or anything that can go a long way in curbing the spread of COVID-19. And then practicing service coordination, knowing to whom you can refer people to get care, especially if they're exhibiting symptoms. That's very important. And having a plan in place with strong contacts that you can refer them, you can refer people there, and you can be in constant contact to sort of grease the wheels and make sure that referral is seamless. So with that, I am going to turn it over to Norm for some additional updates.
Thank you very much, Marlisa, and welcome to the call, everybody. I just want to walk through a few things that are in the mix that you'll be hearing more about in the coming days. One of them is that we are working on creating a more streamlined process for grant amendments during this COVID episodes. So if you are looking at, if you have an amendment you might want to make to your COC program, for example, like if you want to move more than 10% of your funding into a supportive services budget line, for example, we're working on a streamlined process to do that. I'd strongly encourage you to reach out to your field office as soon as possible to sort of get that in the mix. There's a lot going on right now, and we want to expedite these as much as possible, but the sooner we're aware of them, the better. So we are going to look at ways to expedite those amendments for the COC program. We also have a lot of resources out there for on the HUD Exchange about different ways to use COC and ESG resources during to help with infectious disease prevention and preparedness. I'd encourage you to look at those documents. They're very short, just a couple pages, and they describe some of the eligible activities that are available to you from the COC program and from the ESG program. Let's go on to the next slide, please. So we are also, HUD is working on something we're affectionately calling the Mega Waiver, which will be a waiver that covers a few different programs. And so we hope to have news about that in the next couple days. I don't have specifics about exactly what's going to be there, but it will provide some relief from some of the existing program requirements. And we've tried to focus on the ones that people have been asking about and that appear to be a huge barrier to either continuing to serve people or to serve new people. So again, I don't have a lot of detail yet, but we will be publishing that waiver soon. It'll have several parts to it. So please stay tuned. We will try to advertise far and wide as soon as that's published. And that'll cover ESG, COC, HOPWA, and I know that other HUD programs are working on similar waivers. So let's move to the next slide, please. One thing we just sort of want to reiterate, we get a lot of questions about, you know, existing requirements around COC, your COC board, COC meetings, APRs, things like that. We want to sort of stress that we know your number one priority right now is responding to COVID-19. If it's not, we really encourage you to make that your number one priority. We recognize that it can affect your metrics, your things like subrecipient monitoring and governance. We're looking at how best to take those things into account, but we certainly will find a way to take those things into account in our evaluations and future competitions and things like that. So again, we just want to stress the most important thing right now is protecting the health and safety of people experiencing homelessness and those who are working with them. So just want to stress how important that is. We also want you to know that we're thinking about how this will play into future monitoring in the COC competition. We don't have any details yet. We're still working on what the best solution might be. We will let you know as soon as we have an answer to that. And certainly as you're thinking locally about how you're operating your COC, would encourage you to try to be as flexible as possible, understanding that that how you sort of evaluate your local projects and things like that may be severely affected by COVID-19, and strongly encourage you to think through what's a good way to account for that. And moving on to the next slide, please. Just again, want to stress that we have a lot of resources and a lot of our partners have resources. You can go to the HUD Exchange to submit a question if you have a question. We have a big team of TA providers and SNAP staff who are working on answering those questions as quickly as possible. The more you ask those, the more it informs the kinds of resources that we are able to develop. So please use that portal as much and as often as you need to. And we have a couple more slides up here that are just more resources. and we're going to be scrolling through these over the course of the Q&A session. But right now, we're just going to sort of start moving to doing Q&A. So I'm going to start with a question for. Want to actually start with a question for CDC, for Emily. There's guidance out about shelter best practices and how staff should be ready to provide care for people who have been diagnosed with COVID-19. Is there any guidance on how to train shelter staff to do sort of the medical aspects of caring for people who are ill? Do you have any sort of direction or some resources to point people to for how to do that care on an individual level? Emily, you might be muted. All right, so we'll come back to Emily. I take a question about and I'm actually going to ask Brett to take this question about flexibility that we can share with permanent supportive housing and rapid rehousing programs for flexibility with respect to things like signatures for clients enrolling in the program and when people need to sign off on documentation. Obviously, that becomes a huge issue these days with social distancing and everyone working remotely. Can you talk about what requirements we have with respect to things like signatures and original versions of documents and things like that, and hopefully put a lot of people at ease about what's required as far as documentation for example, PSH and rapid rehousing programs? Brett?
Sure. Can you all hear me?
Yep.
Okay, great. So for our programs, we allow electronic versions of records. You don't have to keep things on paper. We also allow for electronic signatures. So if there is a way to take a picture of a document that you signed and uploaded it, and then when you're ultimately able to get back into the office, if you keep a paper file, slip it in there. I think just the important thing is when HUD comes out to monitor that you're able to retrieve whatever documentation you used, whether it's paper or electronic. But certainly, please use electronic signatures as much as possible now.
Great, thank you. We also had a question about supports and resources in small towns and rural communities. I saw, for example, some questions about how there's no space to isolate people who are in when they need isolated units, and in some cases they just really don't have a connection to their public health agencies. So I wonder if Marlisa, if you or maybe David can talk about what and Marlisa, I'll ask you to start, but how should small towns and rural areas be thinking about working with their public health officials, and also how they should, what options they might have for creating isolated units for people who are showing symptoms or are at very high risk?
Well, I'll start by saying, if a continuum of care or, even a provider who's reaching out to their public health department or emergency management officials, if they're having trouble making a connection, now is not the time to sort of, give up. Not that you all would anyway, but I guess what I'm trying to say is that it's time to escalate that request. So if you're contacting your city officials and they're maxed out, contact your county officials. And if you can't get assistance at the county level, then just go up to your state. And so by pushing up your requests for assistance and needs, or quarantine space, and once you're elevating those requests, you can sort of, you're closer to accessing federal resources. That's how I would start. And I can turn it over to you, David, for some additional ideas.
Thanks, Marlisa. I think we've seen some communities really work to identify available hotel, motel rooms and other places that perhaps aren't traditionally a resource that homeless service systems can utilize in the response effort. And certainly working with local public health officials to determine that that's the correct course of action, and emergency management officials to activate the programming that supports that vision is important. And so if communities, again, as Marlisa said, don't have connections with those groups at this moment, now is the time to escalate those requests and really draw attention to this part of the community that will need that resource. So there are certainly other household types that will need a similar resource as we all navigate this moment.
Hi, this is Emily. Can you hear me?
Yes, we can, Emily.
I am so sorry, you guys. I have somewhat unstable internet that's been kicking me off of this. But I can jump in on that question, and then I can answer the previous question if that's okay.
Great, that would be fantastic. Thank you.
So yeah, I just want to echo Marlisa's point here, is that your public health officials are very overstretched, and they do need to hear from you though. So if you hit a closed door or if you hit a barrier, think about how you're going to go around that barrier, how you're going to figure out how to find these spaces that you need, because it is an emergency. And so don't be disheartened if you don't figure out the answer right away. So keep with the public health officials as you can. Bear with them. They do want to help you as much as they can, but they are stretched very thin. And then back to the previous question on how shelter staff can be helping to care for people who are sick. So on the whole, we don't really want the majority of our frontline shelter staff to be having face-to-face contact, very close contact with people who potentially have coronavirus. So keep that in mind. We do want to be maintaining as much distance as possible. If that you have shelter staff that are already healthcare providers, there are recommendations for how they can protect themselves when they're giving that care or helping those individuals. There is also guidance. There's two pieces. There's one that is how there's recommendations for how people are meant to take care of people within their own home that could have relevant information. If there's staff that need to provide direct care to someone, that would be relevant because it's non-medical. It's basically, how would someone take care of a family member who has coronavirus? The same concept could apply in a shelter situation if that needs to happen. And then another thing that's going to be coming is in our communications products that we're going to be getting out soon, we're going to have some information for how people can take care of each other, because we do have families, we do have couples, of course, that are experiencing homelessness together and that will want to be taking care of each other. So we are going to have some information on that specifically. So check out our website for if you have healthcare provider staff, if you have staff that might be providing some care to people that are sick, and then again, hopefully very soon, some information for how people can take care of each other.
Great, thank you, Emily. Very helpful. We have another question about the COC program and possibly ESG. And Brett, I wonder if you could take this on the COC side. We understand there's an ability to extend assistance for up to 24 months, but I assume that's for people in rapid rehousing programs. But is there any added funding that can come to those grants? They're concerned that they're just running out of money for people, and even the option to extend grants longer doesn't really help if you don't have any money. Do you have any recommendations, Brett?
There's no additional money that we can add at this point. Norm obviously mentioned the ESG funding that might be coming our way, and we can think about how to use that. I think take a look at your grant, and if it means you have to serve less people and maybe not enroll new people at this time, reach out to your local HUD field office and see if you can do a grant agreement amendment, or make note in the case file that you're not going to be able to serve the same number of people because of this reason at this point in time.
Great, thank you. And I just also want to point out that in the discussion, hopefully people are following with a chat box because the signature question has even evolved to the point where people are recommending software for encrypted document transmission. So appreciate that. Thank you, everybody. Question about, and I think we've sort of had a couple different takes on this response, but maybe we can sort of go at it again because I think it's one of the most important questions people are facing. But options for people to quarantine or to isolate people within shelters when their shelters are full. Emily or David, do you want to? David, maybe you can take a first shot at this question, and Emily, you can add some ideas. But you know, we have a lot of shelters where they're just trying to serve as many people as they can, and you know, don't have alternative options in isolated spaces. So what are steps people can take to keep people isolated and quarantined when they're either symptomatic or confirmed COVID positive, or maybe just extremely high risk?
Thanks, Norm. I'll take the program design component of that question and then pass it over to Emily to speak to the public health components. On the program design side, as those who were tuned into the CDC guidance of a 3-foot minimum separation between beds for individuals who are asymptomatic, and a 6-foot minimum separation for beds for folks who are symptomatic. That has had a significant impact on some of our larger shelter programs that were using bunk beds, or even our smaller programs, and needing to rethink their space. And as a result of respacing, some programs have not been able to serve the same capacity. As a result, we've really looked at other options, and I think our partners in healthcare are looking at similar decisions of how do we rapidly expand the capacity of a local jurisdiction to safely support a significantly greater quantity of individuals in this moment. And obviously it's a different calculation on the healthcare side in terms of variables. On the program side, for individuals experiencing homelessness, many communities are recognizing that these individuals are at a significantly higher risk of infection, and if they become ill, are more likely to experience complications as a result of the illness, and that has created a planning procedure at the local level that is generally under emergency response officials' domain, known as non-congregate sheltering, which is a type of emergency protective measure which allows local jurisdictions to really think through what would be necessary to put people in response to an emergency or a disaster into setups like dorm rooms or individual motel rooms. And I think the CDC has released some guidance around what the attributes of those spaces would look like in order to serve this population. So, Norm, I don't know if that was too broad. I'm happy, after I pass it over to Emily, to talk in more detail if there's a more focused piece of that question.
So, yeah, I think maybe we can think about maybe providing a specific example for people. I think those kinds of examples nicely sort of give people things to work with. But Emily, do you have thoughts to add there?
Sure. I was just going to frame it in terms of, you know, let's say you've got people walking into your shelter, and you're going to want to do screening So you might have people who are showing respiratory symptoms. You want to have it an area that they can stay in. That might be individual rooms. It might not be individual rooms. It might be a big room where you have at least 6 feet in between people. But then let's say you hear about someone who is actually has tested positive for coronavirus. In that kind of instance, there's a lot of shelter situations that might not feel comfortable being able to isolate that person. So if you don't have individual rooms in your shelter, it might not be the best scenario for that person to stay there. That's where we want this community-wide discussion to happen to figure out the best place for those people to go. So in some communities, they are looking at alternate housing where people do get individual rooms where they can stay if they don't need to be hospitalized. And that's the kind of thing where on the community level, you can get these protocols in place where you're saying, okay, this person has tested positive. We're not going to close our doors and just say that they can't come in. We need to make sure we know where they can go and make sure that they can get there safely. So that's the kind of thing that working out in a kind of coalition-oriented way will make it smoothest for the person themselves.
Great, thank you. David, did you have anything you wanted to add?
I think that's great. We have a couple of examples up, I think, on the HUD Exchange of some different models that are being adapted, and I think several communities are implementing different strategies, including Seattle, King County, and I know USICH has been great about conveying what they're doing to help keep some of the pressure off all of the communities that want to hear from the lessons they've learned.
Yeah, so there is a great webinar from Seattle King County on this that you can get to from the HUD Exchange or from the USICH website. So I want to send this question to Marlisa, and maybe Emily, you'll have something to add to it. But there's a lot of guidance around encampments, but there's less about individuals who are unsheltered but not in encampments. Marlisa, can you talk about what steps we should be taking for people who are sleeping unsheltered but not, maybe not in close proximity to a lot of people or not in large encampments? And you may be on mute right now.
And this is Emily. I can jump in if you would like.
Yep, thank you.
Sure. So when we think about people who are sleeping, on their own, or maybe there's just one other person nearby, those individuals, some of the main things we want to think about with them is making sure to communicate very clearly with them what is going on and making sure that we have good outreach to them in case they do get sick. So there's ways that those individuals might be exposed even if they're not sleeping in a crowded area. So if they're lining up for food services or in a crowded food service facility, there are still ways that they could become sick. So we want to be communicating very clearly with them, and we want to be watching out for them specifically to make sure that if they do get sick, they're connected to care as they need and connected to other resources as they need. This is a very isolating time for everyone, and for those who are already isolated in ways like that, we want to make sure to keep those connections going.
Great, thank you. We have a few questions, and Marlisa, I want you to try to take the first cut at some of these questions. We have a lot of questions about transportation, and I think the questions include things like, how do we find transportation for people who need it? How do we think about social distancing if we're providing transportation, either public transportation or giving people rides or ride sharing or however that works? And then what are the possible sources of funding to help support transportation costs?
Okay, can you hear me?
Yep.
Great, okay. So this has been one of the most challenging concepts for communities to deal with. And I think by and large, what seems to be working is dedicating vehicles so that in other words, public transportation like Uber, taxis, bus systems, typically, I think in any case it needs to be dedicated, and that seems to be what's working the best for communities. So some of the examples that we've heard so far include dedicating EMS vehicles and EMS staff. So we're not talking about emergencies here, but dedicating those, like a few vehicles or staff specifically for transportation, whether it's going to and from, from shelter sites to community health care, or from encampments to community health care, or from shelters to alternate care sites, depending on the flow, the protocol that you're putting in place. But that would be one example. We've heard of local transit authorities dedicating buses specifically for transportation. So, that's a few buses with, bus drivers who are specifically designated for transportation of this sort. And then you're doing the hygiene, the sanitation protocol to, wipe down surfaces and clean between transport. Private vehicles, not a preferred method, but have also been used in some communities where you're trying to seal off the driver from the people who are exhibiting symptoms or have tested positive. So those are some examples that we've heard. But I guess using like the public sources of transportation, but then just dedicating some of those specifically for the purpose of transport have been things that we've heard. You can use ESG funds for transportation under the shelter component, so that's one source of funding. And I think it's also, as Emily mentioned, a community conversation, because it sounds like a pretty difficult prospect for a shelter provider or a continuum of care to secure a metro transit authority bus system. But when you're in coordination with your public health authority, emergency management officials, and local government, that can make the difference in making those sorts of methods of transportation doable.
Mm-hmm. Thank you. Next question I'm going to hand over to Brett about cell phones. Many people want to use cell phones as for case management or just for communication with program participants, just because it's an easy way to communicate, obviously, when they're social distancing. Can you talk about what are those eligible costs, and sort of under what circumstances are those eligible costs for COC and ESG grants?
Sure. Right now, under our programs, you can only use cell phones if they're an overhead cost for staff. So you can certainly pay for them for staff if it's like an organization phone and it's used for work time. We are working with our lawyers to find a way, if we can, to be able to fund those sorts of cell phones and internet access to do virtual case management, virtual healthcare with our lawyers right now. So right now it's not eligible, but we are looking into that. It's certainly come up a lot.
Yes, and encourage everyone to sort of keep checking back, because as we get new waiver authority, as we get new funding, that gives us new opportunities all the time. So hopefully we'll have a better answer next week. And how about, we've had a lot of questions about hazard pay and overtime and things like that for staff who are working, doing incredible work during this time. Brett, can you talk about what the sort of guidance is about how, can you pay overtime? Can you pay sort of hazard pay? How does that work?
Sure. You can, if it is in line with your agency's policies and procedures and you're paying it. There are a lot of rules. The specific reg site is 2 CFR 200-431. So long as it meets the requirements of that section, you can pay for it. So if your organization pays for it equally for grant-funded and non-grant-funded activities, you can include things like admin leave. So we've had a lot of questions about, we shut down, we want to pay staff for 2 weeks, is that okay? And the answer is, if it's in line with your policies and procedures for payroll and personnel compensation, then absolutely, that's fine. Same with incentive pay, overtime, as long as it's how your organization normally does business.
And if it, not everyone's gone through this, so if they didn't have a policy, but they want to create a policy for the current situation, is that something they can do?
Yes. And this is another thing, stay tuned also for additional guidance.
Yeah, I'd just to piggyback on that, I'd strongly recommend everyone who's interested in what the ESG funding that Congress just passed, if you're interested in what that will be able to pay for, the actual legislation actually has quite a bit of information embedded in it. For example, it's clear that there's no match required for that, and it actually has some answers to some of these questions, including things like hazard pay and things like that, and including the 60% shelter cap. So I'd encourage everyone to either, look at the actual legislation, or I know there are a lot of organizations who are summarizing the legislation who I think have already put stuff out. We are obviously working to get information out as quickly as we can, and so we'll try to get that out to everyone as quickly as possible. Just because it's not written into the legislation doesn't mean it is something we won't be able to do, but there's clearly stuff that you'll, I think, be happy to know is in there that you can do now. The other thing I wanted to mention to give people a sense of, well, $4 billion sounds like a lot of money, but is it really a lot of money? Just to give sort of reference points, and it's certainly not going to be this way for every community. There's going to be a formula, and it's not quite the same as the current ESG formula or the COC program, but the current ESG, your 2020 ESG allocation was about $290 million nationwide, and so $4 billion is a lot more than that. And currently we fund about about $2.2 billion a year in COC funds. So $4 billion is also a lot more than that. So it is a very significant amount of money, and certainly worth starting conversations about what's the most efficient and effective way to utilize those funds. So Brett, thank you for those responses. Marlisa, we have a question about extended shelter stays due to the shelter-in-place orders that some states are giving. Does ESG allow for recipients and subrecipients to extend shelter stays? What are the rules about lengths of shelter stays?
Well, there are no current shelter stay limits for ESG. Of course, performance-wise, we're always encouraging the shortest shelter stay with positive exits to permanent housing. So, that should still continue to be a focus. The sooner that you can exit or assist someone to exit from shelter to a permanent housing setting, the better. Under these circumstances, understandably, everyone is consumed with COVID-19 response, and if your best option is to extend someone's stay past maybe a programmatic limit, in other words, a time limit that's been imposed by your program or by your recipients, then that that would be a good choice to keep someone safe and sheltered as opposed to unsheltered or in an unstable situation. So bottom line is ESG at the federal level, we don't have a cap on shelter stays. Exits to permanent housing is, of course, the ideal situation, but if the safest option is to keep them in the shelter, then by all means adjust your programmatic shelter caps or any shelter limits put in place by your recipient.
Great, thank you. Also, just we have some questions, people asking about, as always, about whether the webinar will be recorded and available, and specifically whether the chat boxes will be recorded and available. We are keeping track of the chat box text, and we will make that stuff available. So I guess we should have warned you to watch your language, although it's been pretty good so far. So we will make those available as soon as we can after the session. Want to, Brett, if we could tackle the question about IDs, identification. Can you talk about, so a lot of people don't have ID and it's very hard to get ID these days. So if you're, trying to get housed through a COC or ESG funded program and you don't have your ID, what options are there available?
Yep, so for our programs to provide assistance, we actually just require that you document homeless status, and then where necessary for PSH disability status. We know documenting disability status is a problem right now, and that is also on our radar. But where you're talking about a rapid rehousing project or somewhere where you just have to document homeless status, you actually don't need an ID. You don't need someone's social security number. You don't need someone's driver's license. So we would recommend that you don't ask for that right now. If landlords are looking for that, see if you can create a little bit of flexibility, maybe put something on the lease where the agency is taking some ownership until we have a chance to go back and offices open and you can get things like driver's license and social security cards.
Great, thank you. So this is a question or recommendation for the audience today about, it would be, we are obviously trying to urge local, county, and state health departments to work with continuums of care. If you have recommendations for how we could better support you in your work to make those partnerships happen, we'd love to hear your thoughts about that. And, again, we want to promote these partnerships as much as possible. And I know Emily and our partners over at CDC and throughout the federal agencies are also very interested in promoting these partnerships. So if you just want to throw in the chat box any ideas about what would be helpful in that respect, we would love to hear those. So we had a question come up about family composition. So we have situations where a family household is experiencing homelessness, and one individual in the family is ill and has to be isolated or goes into isolation. Brett, can you talk about the eligibility rules around like serving their children or serving other household members, or how should people think about what happens and who's eligible and all that stuff when families are potentially being separated for quarantine or isolation?
Okay, let me see if I'll start, and then if I miss something, let me know, Norm. So yep. When you enroll a household, they're considered one household, they're considered eligible. So if somebody has to leave the household because of quarantine or isolation, you're still able to keep assisting the family that remains in the unit. We've certainly seen cases in the past where it was a single parent and the parent had to go into the hospital, and the question came into the help desk, can we let somebody else move into that unit and take care of the kids while the person is there? And the answer is yes. There might be some rules with the local landlord. You might have to add them to the lease. You might have to reassess how much you're paying for rent in those cases, or how much they're paying for rent. But certainly you can do that in a case where a parent has to leave for any reason like isolation.
Great, thank you. Emily, a couple questions I want to throw your way. One is about if a community is offering portable showers or even hand washing stations at encampments. What should outreach workers or communities be thinking about with respect to sanitizing those either showers or hand washing stations or whatever facilities they have? Can you talk about what practices people should be using for those kinds of portable facilities? Emily, do we still have you there? You may be muted.
This is Marlisa. Can you hear me?
I can hear you fine, yes. Do you want to?
Okay, I think that Emily and I are having the same audio issues. But Emily, you can cut me off as soon as you get back. But those do require regular maintenance. So if you have, the portable restrooms, porta-johns, typically the people who set them up can also provide routine maintenance, and then as well as the hand washing stations. But however it happens, like the same types of wiping down the surfaces that are touched a lot with disinfecting them as you would just like another sink. And then, I mean, it may actually require more frequent maintenance just by virtue of how often it's being used, making sure that clean water is available, soap, that, something to be able to dry people's hands is available, that it's fully stocked up. But that's a really good point that, the hand washing stations and the portable showers and the portable toilets are good to have, but they absolutely need to be maintained on a regular basis so that they themselves don't become a source of infectious disease spread. I don't know if Emily's back or if David has anything else to add.
Well, let me follow up quickly, Marlisa, with a question about, so all those things you talked about, are those all eligible ESG costs?
So as far as street outreach goes, currently you can provide toiletries, hand sanitizer, toiletry kits, food, water. I mean, in the worst case scenario, if even to provide jugs of water with soap is better than having nothing, like no hand sanitizer, nothing of the sort. So even some method, even if it's rudimentary, if you have clean water and soap that you can make available, that's something that you could pay for with ESG. We haven't actually gone so far as to say that at this point that hand washing stations or portable toilets or showers are eligible under street outreach. It's more of the consumable items for encampment residents or other people living in unsheltered situations.
Okay, so and that's probably something people will want to check back in on frequently. David, were you or was somebody else trying to jump in?
I just wanted to reference for folks who are struggling with even how to source or conceptualize acquiring those kinds of products like a shower trail or portable hand washing stations. Emergency management has those contracts, and partners like the local Red Cross or other folks know how to deploy those. They may not be active in this particular event because it's happening everywhere. but they will know how to acquire them. So if it's a question of acquiring them versus paying for them, I just wanted to separate those two elements.
Great, thank you. We had a question about balances of state, COCs, and if we're recommending people working with their, and David, I think you probably, I'm probably going to throw this question over to you first, but if we're talking about coordinating with a county health department, I mean, that's kind of balances of state, and statewide COCs sometimes cover, dozens or sometimes over 100 counties. Is it just going to be easier for people to coordinate with their state? What's the balance? How should they be thinking about that level of coordination?
Sure. I think you've kind of hit on the critical component of that, which is we have to be able to sustain and manage the coordination. So I know some states don't have robust statewide public health teams, and those resources have been developed really at a local level. So you may have one county that has a very strong public health component, particularly around urban centers where public health is an aspect of everyday life. And you may have adjacent counties where the public health team consists of a part-time employee. And so it's really, I think the approach I would take is trying to acquire kind of whatever level of coordination helps you to identify problems and deploy solutions. And certainly in our balance of state operations, coordinating with the statewide public health department. I was just in California, and in a state that size, really having a strong public health department at the state level is key, and then at the county level also, when you're looking at their very large jurisdictions, is critical. So figuring out who the chief medical officer is for a county and who the chief medical officer is for the state, those are firm connection points for people to connect with. And I know Emily's having some audio trouble, but if you're back on, Emily, I don't know if you have any suggestions too for corralling folks on the public health side at that balance of state level.
Yeah, I don't see Emily on the connected list yet, so so we can check back with her once she checks in. So let's see what other questions we have here. We did have a question about whether the supplemental, this is a very, very general question, but about whether there are FEMA or any of the HUD funds that are coming through are available for rapid rehousing. And I mean, boy, do we have news for you. A lot of it is available for rapid rehousing. And in fact, I think this is going to be one of our most important tools with the new ESG funding and potentially with CDBG funding and much of the other funding that was available through this supplemental appropriation. So again, I'd urge you to check back with on the HUD Exchange to get more information about what funding can be used for. But in the meantime, I think it's safe to start planning heavily for trying to max out and expand your capacity for providing rapid rehousing to people. And that's certainly, especially thinking about as people are going into hotels and other temporary isolation areas, that housing them is often the best option available, and starting to think and plan for how you will be able to do that, because there will be a lot of resources available to do that. Just to give you a sense of scale here, for those of you who have been around for a little while, when HPRP passed in 2009, that was about $1.5 billion in funding. And again, reminder that the ESG funding, it's for more than just prevention and rehousing, but it's about $4 billion that's taking place over roughly the same timeline. So again, a lot of resources available and really worth trying to figure out what's the best way to take advantage of those resources. We're coming up near the end of our time here. I am going to go ahead and start wrapping up the session here. Want to strongly encourage people to continue to submit questions through the AAQ. We are very interested in hearing what questions you have, what concerns you have, and that greatly informs our technical assistance and other resources and publications we put out, and will also help us as we think about the policy responses going forward. So again, strongly encourage you to keep sending in questions. If you are having problems, I want to reiterate Marlisa's advice from earlier about if you are having problems where you think a major shelter might need to close for some reason, and you want to, jointly problem solve with us or with other partners, please reach out as quickly as possible. We have some experiences and partnerships that we want to help bring to bear to help you with those issues. So please reach out to us through the AAQ is the best way. But if you want to contact your field office, that's great too. And if you want to, reach out to, one of the SNAPS people, that also absolutely works. So please reach out if you can. I'd like to just thank all of the panelists today. I want to thank John Gibbs for kicking us off today, our acting assistant secretary. I want to thank CDC, VA, our TA providers, SNAP staff. There have been a lot of people in the chat box. We sort of padded the chat box with people who could answer and resolve questions. So thank you all for joining. The chat information has been fantastic. And mostly I want to just thank everyone for the tremendous work you're doing. These office hour sessions have been a little challenging because many of you have been really 24/7 dealing with this for many weeks now. And for some of you, it's just sort of starting to bubble up, and we want to make sure we provide information to you no matter what situation you're in. But thank you all so much for the incredible work you're doing and just putting yourself out there to, save people's lives in this sort of unprecedented time. So thank you all. That concludes this webinar, and we will talk with you again soon. Thank you very much.